We're hoping to have some time for questions, but we do have to keep on. Our next speaker is Professor Hugh Rushton, who is a Doctor of Science from London, England, who has worked for many, many years on programs and care evaluation, validation studies, methodology, and looking at the reason why, or the interpretation of why hair loss occurs. And Hugh has agreed to speak on significant growth following effective medical treatments in men and women with pattern hair loss does not involve the conversion of vellus hair to terminal hair. Where does the observed hair growth originate? I hope he tells us.
Thank the talk, and also they've been a very nice room that's got wall lights on the back hair. Very good. You're all good. Basically, we started to look at work that we've done over the last 30 years. This is a re-examination of some of the work that we published since about 1980. I have no conflict of interest, and I want to just start to outline the reason why vellus hairs are thought to be part of the story. We all know that the clinical changes occur because we get a reduction in the growth rate, there's an increase in telogen, and particularly telogen hair that's less than 3 centimeters long. At the same time, following that, you then get an increase in vellus hair. And the definition of the vellus hair is hair less than 40 microns that hasn't grown longer than 30 minutes. Then hair density changes. Now, all of the studies, many of you have seen some of my work in the past, revolve around this area of. And this is a method where you pluck out all the hair from a given area. You often get 100 to 120 hairs. What I want to show you is that if you look at these hairs here, this is one hair. And then there's sometimes two. And further down you might have a cluster of 3. That becomes significant later on. Here's an example of what we do. We pull out all the hair, and not only that, we get to measure the growth phase, the length of hair, and the diameter. So what does unit area diagram give? Well, it gives us the fundamental parameters for the hair area. The only one it can't measure is linear hair growth, because once you take the hair out, there's nothing there to measure. So looking at the diameters and the length, they're particularly important in vellus hair definition. So what do we call a vellus hair? Well, we know there's a population of fine hairs, and vellus hairs fit into this group. They tend to have short cycles, and they're shorter than the thick hairs. So how do we define a vellus hair? If you look at most of the biopsy work or most of the photogrammetry, they often use a diameter of less than 30 microns. Now, unfortunately, an emerging anagen hair will have a diameter less than 30 microns. It is often mistakenly classified as a vellus hair. The actual quantification of a vellus hair is this definition of less than 40 microns, less than 30 millimeters. And they rarely grow over than 30 millimeters. So, unfortunately, if you don't have a hair length corresponding to the diameter of the hair that you're measuring, you sometimes will get false results. So what's the evidence supporting vellus hair conversion to terminal hair? Well, as you can see, I'm seeing people here, where the biopsy work suggests that basically there is a conversion of vellus hair to terminal hair. And even I published work using the percentage of vellus hair back in the 2002. So even I had to put my hand up and say, this is different. I'll give you an example. Say, for instance, you have 100 hairs per centimeter and 50 vellus hairs. And yet you stimulate hair growth, and you get 200 hairs, but the vellus hair population, the absolute population, still is 50. to effectively half the percentage of those hair. So quoting data in percentages is dangerous. We ought to be presenting data with absolute value. So what did we do? I went back and reanalyzed all the raw data I had for several publications. And basically, what happened was, as you can see, we took men, we looked at minoxidil studies. This is when, in the early days, we only had 2%. We looked at finasteride, before completion, so 1 milligram per day. Then we looked at the combination of minoxidil together with anti-androgens. And if you can see, that the main thing is that when you stimulate hair growth, and there's significant amount of hair growth, there's absolutely no change in those hair growth. Now these studies all run 12 months. We've got absolutely no change in the vellus hairs and square segments. If you look at the female overview, we looked at oral cyclophone acetate to be damaged with that. All these women had serum ferritins above 40, and then women up to 40. High metabolism, no violence, ferritin level balanced in growth rate. But as you can see, cyclophone acetate, with inhibitors increase the hair density over 12 months. But again, there's absolutely no change in the vellus hair population. Minoxidil, if you look, we did some 5% studies back in the early 80s, 80s. We got a significant increase in using 5% minoxidil, but we had absolutely no change in the actual vellus hair count. So what does this tell us? Well, certainly the data would suggest that the vellus hair to terminal hair transitions don't take place. Messenger and Goodwin pointed this out some time ago and were concerned that basic efforts have been into treatment. You've got significant terminal hair. But if you think about it, how can a vellus hair convert in 16 weeks to a terminal hair? Imagine it has to go through all the transition. To actually get a measurable hair for 16 weeks. It didn't seem logical. So what is the basis for where the hair grows from? Well, we have an idea that perhaps the vellus hair does convert to terminal hair, and there's new vellus hairs generated. That's the political hypothesis. The problem with that is that there's very few people that actually have studied longitudinal studies of vellus hairs and terminal hairs. Now, I've already done this. Followed 11 hairs for 4 years. The first 2 years, they remained untreated. And the second part of it, from years 3 to 4, finasteride was introduced. Now, during that time, he observed dormant hair follicles. He didn't find any conversion of vellus hairs to terminal hairs, and he didn't find any new vellus hairs appearing in the area. We also had work from an Italian group who looked at a suggestion that perhaps the hair growth might be due to reactivation of the telogen phase. And it's an interesting possibility. I actually like to think it would be more of a sleeping phase or a dormant phase. So what does it actually tell us? It says, well, basically terminal hair growth is on decline. And everybody can see it. You can see the hair growth. But the analysis doesn't support the hypothesis that it's because you convert the vellus hairs to terminal. The data supports the view that perhaps during the progression of the hair, some of the hairs go between intelligent and when they've got exogen, remain dormant. These are non-vellus hairs. These are the terminal hairs that got extended phases and sleep for longer. And they're actually there. And if you remember the slide where I pointed with 1 hair or 2 hairs, those particular follicles could have 2 hairs sleeping. And so that led us to think that if the treatment can reactivate these sleeping hairs, then that could explain how not all works, how some of the treatments which are supposedly influencing female and male hair can actually give you a significant clinical response. It also helps you look at what treatments might work in the future. It doesn't actually address the transition from terminal hair to vellus hair because of the actual problem. And they're slightly different problems in the male and the female, but in essence, the vellus hair population remains fairly stable at a certain point. As it deteriorates, it stays stable, and then what happens next is that the sleeping dormant hairs just sit there, they're the ones that actually generate the hair growth following effectively. Thank you.
I was going to ask one question. Why did it take 25 years to come to this point?
Good question. Well, it's like anything. It's like when you're young, you follow what's the general way of presenting data. But then you get a bit older, and suddenly I say, maybe it's not quite what we thought it was when we actually did the original work. And I had to talk to you, but I had all the little data. Well, it's time to go back and look. I couldn't quite understand. I'm 16 years old, yes, certain areas of music quality. It just didn't make sense. So that caused me very much. And some of the work are actually very similar. The subject to a paper that's been submitted to the experimental colleges looking at a lot more but it's just to look at this change in our thinking and pathophysiology, male, female, and male. Vellus hair is not important.
Thank you very much. I think what we'll do now is field some questions from the audience for a few minutes, if you have any. Any questions coming forward? Okay, please, Neil.
Is the target of implementation associated with the experiment enough to make our patients have a positive therapeutic response long term, or do we need to have some of that? Those later determined there's a program designed or with that should be targeted on stimulation.
Who are you directing that to?
This is a really important.
All right.
So, if you, it sounds like, so if you're a price range, you'd say there's a difference between vellus and curves. So, vellus hairs are present from essentially after birth. The ratio for whitening studies are 1 to 7. So you're showing that the vellus less than 40 microns are not changing. But the 40 to 70 micron that we call indeterminate would be the ones that would revert the full terminal. So you're not. So is that consistent? Is your data consistent with the idea that you have a miniaturizing population that's not terminal, that length is greater than 70, but just an indeterminate population of 40 to 70? And with all this biopsy data from whiting and others, clearly there's a miniaturization follicle ratio of terminal or large follicles to small follicles decreases in biopsy.
When we looked at a diameter level in normal female, the cut-off point was round about 46 microns. And a hair that's 50 microns will grow just as long as a hair that's 70 or 90 microns. So there's no difference in its ability to grow. If it gets above 46 to 50 microns, it'll grow as it should do in another life cycle, 3 to 5 years of that person. The growth rate might be different.
They're probably spending a lot more time schooling, is what you're saying.
Not in a normal person, no, there's no difference. But when you get pathological states taking place, then the imaging phase is still the same, but it's then shared with exogen that is not replaced. And that's where we get the reduction in the hair density.
George, that answer, or you just
it's not consistent with the biopsy, right? So when you biopsy a woman with phenotypic hair loss, you see a lot of small hair follicles.
Yeah, the problem with biopsy is you look at a very small population, and you're not sure whether or not they could be the emergence of a sample in the hair. When you take a large sample of hair, say 150 hairs, you get a much better understanding of what's actually in that group of hairs.
The biopsy is about 40 to 50 hair follicles, so it's not that small.
Well, it depends where you cut the biopsy from. That's one of the
Horizontal section. So
Yeah.
all I'm saying is, I think the data is compatible with the way. I think there's an indeterminate type of follicle that is very important that can be rescued with minoxidil, and the size can change of those, I would imagine. So I'm just trying to figure out how we should be thinking about this. Anyone else wants to?
Well, obviously, we're going to have to think some more. So it looks like the indeterminate hair and the tenogen hair follicle, maybe those that we should be looking at enlargement. Janet?
After the discussions of prostaglandins, I'm just curious, toxin inhibitors like ibuprofen are very commonly used in our population. Is there evidence that they affect hair growth?
Yes, there is. And in fact, I want to relate here who was actually in front, who actually, when I was first talking about my interest, pointed me in the direction of the anti-inflammatory agency. They Ross. Yeah.
Did you all hear that the toxin inhibitors create hair loss?
I was associated with
Yes, what you say, Janet?
Bruce Fellow from Southern California. Well, my question is, one of the big topics, but there's nothing on the market, would a topical anti-androgen, the only one that comes out is Nizoral so far, is there a topical anti-androgen that you could apply that would help impede hair loss?
Currently, they haven't tried to do properly. So you may have some questions about that, but the main one that's registered by the FDA is finasteride, and that's always been used as an oral antibiotic. But one of the issues with using anything topically is that you put it on your pillow and your wife is next door to you and you don't know how much of that anti-inflammatory she's going to have, and if she's pregnant and she's having a male baby, that would not be something we would always be happy with. So there's an issue, a big associated risk, which I think most pharmaceutical companies would not be very happy about.
Because they had like Nizoral, I know they did a study in the 90s, Nizoral, topical, Nizoral, and
Yeah.
but no one ever pursued it, maybe because of patent reasons, but never pursued. But there's nothing really showing that it helps with you apply something topically it would help.
There's always the issue about getting something in the skin as well, down to the bottom of the hair follicle where you would believe an antibiotic would work, wouldn't it work?
You feel it would?
Valve. Sorry about that. We've used topical. If you saw on that slide, we combined 3% also with topical anti-androgen. And unfortunately, we can't use dichlorophenic acid. We can use dichlorophenic acetate, and I can guarantee I cannot have sex with that in the topical lotion. You've got a big hair follicle that sends the drug down and gets into the system. So it grows hair. So if you use topical dichlorophenic acetate together, we've also done finasteride, probably with biomacro. The most effective is dichlorophenic acid. You do get systemic issues, but it does grow hair. When you combine it with finasteride, two together, seems to be the most effective treatment. It's not available in other ways.
But there would be systemic absorption for preparation.
There is some systemic. Depending on what concentration, you probably see 2,000 to the reference.
One more comment, there is a topical anti-androgen pass along at the article in my briefcase that study was supposed to be in Europe, so let's stop by the Rushton Park.
Okay, thank you.
Let's try this again. Table that. How long can you use topical steroids on the scalp, and is it causing links like that?
And that's an excellent practical question. In our studies, and we've had patients using these steroid preparations for a year plus, but we realized that moving forward in larger studies where we're aiming for widespread usage, that will either have to lower, again, steroid potency that's utilized and or give rest periods or cycle in case of using the product. Because that is a concern in the long-term response.
I'd like to respond to that. I was serving on the FDA advisory committee a number of years ago. They did look at the topical application of hydrocortisone to the scalp, and they were able to produce adrenal suppression within 2 weeks. It's very problematic to us.
Thank you, Dr. Spitzer, we've seen in Australia. Just following up on that, can I ask Dr. Sadie, do you biopsy all female patent alopecia or anti-genetic alopesia if typical, and or if they do present with scalp burning or other symptoms, do you treat them standardly with topical corticosteroids in addition to the other topicals?
At this point, our paradigm is we do biopsy all women with use in it, and we do blood work, as everyone has mentioned. We segregate them again into this inflammatory immunoreactant group versus not. Those that are in this immunoreactant group are treated with more intense anti-inflammatory approaches, which they have again these topical corticosteroids, low energy light, and chloroquine.
Thank you. Do we have one more question over here? 3.
Just a clarification with the OX1 issue. Yes, indeed, we can block certain prostaglandins, but it can also block ETP2. And at the same time, if we use OX2, we may even have more prostaglandin F20. So, politically speaking, it doesn't make sense that inhibition of OX1 will actually reduce that. But I think that's a comment. The question I have for Dr. Bloom is molecular readouts in an important pathway. Can we seek some maybe immunohistochemistry, or can we seek some more evidence that this is more of the non-important 5 receptor rather than the 1 to 4? Because the non-important 5 receptor is a marker for secretion, plant differentiation. Can we
This was not the topic of our research in this project, but for screening first different genes involved, then we should in the next step go further down and think what are the responsible pathways. So the key interest is first to identify upregulated or downregulated and then look in detail in the most promising.
But that's one of the 3 promising that is covered, right?
Yes.
Okay, so it's a logical step to seek that information.
We've come to the end of the questions, it seems, so I'm going to take the opportunity at this point to thank my co-chairs and all of the presenters, and certainly all of you interested participants. Thank you so much. The session is closed.